My name is Lynn Kinst. I'm the Executive Director of the Hemophilia Council of California, and want to welcome you to this evening's webinar, Got Diagnosis, Women with Bleeding Disorders, which is part of our Public Policy and Advocacy webinar series. So just getting started with a few housekeeping items. First of all, we want to say thank you to our sponsors. Takeda is our platinum sponsor, and then bronze sponsors, BioMarin, Novo Nordisk, Sanofi, Bayer, the Hemophilia Alliance, and AbbVie for supporting the webinar series. We're going to be talking about the difficulty that many women have getting a diagnosis, and I'm sure that some of you have those stories, and I would feel free to share that if you're comfortable in the chat. Want to also remind you that the Hemophilia Council of California and our speakers today are not providing legal counsel or medical advice. And I think that's especially important on a topic that we're discussing today. None of our speakers are physicians. And even if we were physicians, we really would not be able to speak to your individual situation, diagnosis, or treatment in a dialogue that we would have, over a webinar. That's a individual conversation that you would need to have with the provider. So the experiences that individuals share are their experiences, and they may be instructive to you in your own medical journey, but we just want you to understand that it is not medical advice. We are here to coordinate statewide access, education, and advocacy on behalf of individuals living with bleeding disorders and rare and chronic conditions here in the state of California. And specifically, we advocate to protect access to care, promote progressive treatment options, and advance the quality of life for individuals and families impacted by inherited bleeding disorders. And our mission is to improve access to care and treatment options for all folks impacted by bleeding disorders in California. For tonight's webinar, what is the problem that we are talking about? We are talking about barriers that women in particular, and to some degree all patients that have potentially more mild bleeding disorders, face in getting accurate diagnosis. And there's a number of factors at play. Some of the most common ones that I hear about are, there is just systematic bias, right? So there is bias in the medical system that we are becoming more and more aware of that sometimes works against people accessing proper diagnosis and treatment. And that is true not just in bleeding disorders, right? That can be true across other types of illnesses and that patients may face. There is also a difficulty recognizing and defining excessive bleeding. And I think one of the challenges with that is that men and women don't necessarily bleed the same way, right? So physicians who have been within the bleeding disorders community treating men who bleed have a certain expectation of what that's going to look like, and it may not look the same for women. And then also, it can be difficult to measure, right? When we're having a bleeding episode, it's not like we're actually, the bleeding isn't coming out of our body into a container that we can collect and measure how much it is, right? And so it can be difficult to really quantify what that looks like. Again, similar to what we've said, it doesn't always look like the textbook, especially for women. It doesn't look like what the doctors have studied in school. And then the last point, sometimes we have a great deal of difficulty being referred to the right type of hematologist. And what do I mean by that? Well, what I mean by that is that in hematology, there are really, in its broadest sense, sort of two classifications, right? There is benign hematology, which is non-cancerous types of blood disorders. And then there is what really the vast majority of hematologists practice, which is more treatment of disorders like leukemia, like blood cancers, right? And so if we get referred to a hematologist, maybe because of our doctor or because of our insurance that isn't familiar with bleeding disorders, they may be less likely to get us an accurate diagnosis. Okay, so briefly, like if you are struggling and you're like, okay, I think I might have a bleeding disorder, who are you going to try to go to for help, right? So there's kind of three primary types of physicians that you might see. Initially, you might see your primary care doctor or your PCP, primary care provider, and or an OBGYN. Because of course, for women, oftentimes, but not always, a lot of our bleeding issues kind of have to do with the bleeding that we do during our periods and our monthly cycles, right? And so it might be something that comes up with an OBGYN. You might have had someone might have had difficulty during childbirth with hemorrhaging or bleeding. And again, might be something that our OBGYN observes. Some of whom are better than others at understanding the potential of a bleeding disorder and its impact on what's happening with our bleeding. Sometimes, unfortunately, an OBGYN just doesn't have the specialization or understanding of a bleeding disorder. And so it may not be the first thing they think of, may not even be the second or third thing that they think of in order to offer a referral. And then lastly, really where you want to end up if you think that you have a bleeding disorder is with a hematologist that has expertise in bleeding disorders. So as we were talking about, a hematologist who specializes in benign hematology and really has some expertise. Quite often, the best place to find that individual is going to be at a hemophilia treatment center, but not necessarily always. And sometimes because of your insurance, you may have difficulty accessing a hemophilia treatment center. Okay, just a few points here as we dive in a little bit more on testing. So I recently got to see a presentation by Dr. Johnson at HFA, and a couple of points that I have here I'm really borrowing from her excellent presentation. And she talked about how ideally all potential carriers should undergo genetic testing to confirm a diagnosis of hemophilia, and that would apply, I would say, to all bleeding disorders, and establish causative mutation. So really any family history of a bleeding disorder is a reason for genetic testing. And anytime that bleeding is impacting daily life and activities, it should be investigated. And a really important point with that is that when bleeding, the definition of how your bleeding is impacting your daily life is not, and oftentimes we make sort of adjustments, right? Like we adjust our lifestyle around the bleeding that we're experiencing. If we're having to make those adjustments, then that bleeding is impacting our daily life. And it's something that we should be investigating and seeing if there is treatment available to assist us. Types of testing to consider. So we could do an hour probably on each of these topics easily, and I don't unfortunately have the time tonight to dive into them, and really would want a physician to be able to really go into this, right? But when you're investigating and trying to get a diagnosis, there's a few different types of testing that may or may not be offered to you or that you may want to ask about. Genetic testing is going to be the most definitive, right? That is going to be the most definitive way to determine whether or not you actually carry the gene and are therefore potentially experiencing a bleeding disorder. Factor levels are another, so the blood factor levels is another way that physicians can investigate whether or not you may have a bleeding disorder. And then typically PK studies, so that has to do with if you're on treatment, how that treatment's working for you, how your body is metabolizing the treatment that they're giving you, and how long it's lasting in your body, right? So that's going to be further down the road, less likely to occur at the beginning of your journey towards diagnosis. In my experience, both personally as well as collecting stories from people, I think that one of the biggest barriers that women face is difficulty getting referred to the proper expert who can really investigate the symptoms that they're having and help them determine a proper diagnosis, right? So insurance challenges is a big barrier. And feel free, like if you have experienced this would love to have you pop in the chat with some of the barriers that folks have faced in their own personal journey. Again, if you feel comfortable sharing. But it can be very difficult to get a referral. Briefly, I will share a personal story. So my father had hemophilia B. So I had obviously definitely carried the gene as the daughter of someone with hemophilia. And when my daughter was born, I wanted to get her testing and I wanted to figure out if she had gotten the gene from me. But when I tried to get a referral to the Hemophilia Treatment Center for my daughter, the insurance company would not refer her to the Hemophilia Treatment Center. They would only refer her to a hematologist that was in their network. And that hematologist, because I investigated kind of, what their experience and background was, they were primarily working with leukemia patients, and they only had one pair of twin boys with mild hemophilia in their entire practice. So they had very little experience. I had to find a different route in order to get my daughter tested. And that was back during the time, thankfully, that My Life Our Future was still opened, and I was able to find a way to get her tested through My Life Our Future. But again, it takes, unfortunately, sometimes really some persistence and exploration of different routes in order to get to a place where you're going to have that proper expertise and get the correct testing ordered. Not these quotes directly, but this is a point that I just learned in the HFA seminar that I mentioned with Dr. Jill Johnson. And this is, I think, a really important point as it relates to access to treatment that she raised. So we use and have historically used in bleeding disorders this term carrier a lot, right? We've said women are carriers. And then we even at some point started to adopt the term symptomatic carrier. Well, the issue with that is that in medical genetics, so in anyone sort of working in the medical field, but potentially outside of, not super familiar with the bleeding disorders community, by definition, the term carrier means someone who has the gene, but is not affected by the disorder, right? So you see the quote from My Health Alberta: a carrier is a person who can pass an inherited genetic disease to their children, but does not have the disorder. So when we submit requests for testing, when we ask for referrals and we use the term carrier, the medical person that is reviewing that, or the claim person that is reviewing that, they are seeing a term that makes them automatically think this person is not impacted by the disorder, and therefore why should they need this testing? Why should they need this referral? And so it's something that we really need to think about changing our language, right? So we need to describe patients as having a family history of bleeding disorders. We need to document the related symptoms and request testing and referral to be in order to confirm the diagnosis. And so this is an important thing that it's sort of a simple thing, but it's a very important thing that we really need to change our language and be sure that providers update their language in our medical charts and our insurance paperwork to make sure that that simple language change isn't part of what is creating a barrier for us to get access to treatment and to diagnosis, or I should say diagnosis first and then treatment. So some other general tips as we think about what you can do to advocate for yourself, and we're going to talk about this in a little bit more detail with some examples and also open up for some discussion, but document everything, right? So it's really important that you document, log your symptoms, document with photos where it's appropriate and helpful, because those are going to go a long way to helping you advocate for yourself and helping the doctors really understand what you're bringing to them. And like I said before, sometimes it really does take persistence. Unfortunately, because this is a question that has come up in the past, unfortunately, GHPP does not provide coverage for diagnostic appointments or testing. So in order to qualify for GHPP, you must have a diagnosis and have that documented properly, and then, go through the rest of the process in order to get GHPP. I know that there was a comment that somebody said they had a diagnosis and they still haven't been able to access GHPP. We have had some women who have had difficulty getting their GHPP applications approved. And I've really, as I've been dialoguing with GHPP about that recently, and we've been able to get a few of those decisions reversed, I think some of that has to do with the language, again, that we're talking about. So GHPP is going to look at things like factor levels and need that testing in order to qualify a patient, as well as the doctor's notes, etc. And so that is something that, we can work through with individual patients if they haven't been able to qualify. But unfortunately, it is not a tool in order to get a diagnosis appointment. And then there are a few instances where CCS, I should say, does have limited coverage for certain types of diagnostics, but it's not really the type of diagnostics that's applicable within the bleeding disorders space. So unfortunately, those are not tools that will help us. If a patient is on Medi-Cal, certainly then they should be able to get the appropriate referrals. And then, private insurance is kind of hit or miss depending on your insurance, etc. So somebody asked what GHPP was. Good question. I apologize for not describing that first. It's the Genetically Handicapped Persons Program, and it's a program in California that allows patients with a handful of rare chronic conditions to qualify for some medical coverage that other adults typically aren't able to qualify for. CCS is California Children's Services, and it provides coverage for children that have sort of rare, chronic, and acute medical conditions. So I think, this is like a translation of someone. There's a patient who has a son and brothers with hemophilia, and they have gotten a range. So it looks like they've been tested at one time and they got a 33, and then another time it was 76. And so, which is one of the difficulties with factor levels, right? They can kind of be all over the map sometimes. Our hormones can affect them. That's a pretty broad range. I don't typically, again, I'm not a physician. I typically haven't seen a range quite that broad, but I know personally, even for myself, I've had about a 20-point range in the test that I've had done over the years at different points in time. And so this is a situation where the referral to the hematologist was to somebody who was not an expert in bleeding disorders. And so it's probably a case of needing to really kind of go to battle with the insurance company and figure out how to get referred to a hemophilia treatment center where there's a little bit more expertise. So that is kind of a good segue to the slide that we're on. Keep in mind that the initial decision from your insurance company is never final. Every plan has an appeals process, and you should follow that appeals process because a high percentage of appeals get overturned. And so you're going to want to get the denial in writing if at all possible. And then when you get that denial, it should include information about how to appeal. They should also have that information on their website. And you want to follow those instructions exactly and within the timeframes, because otherwise they will try to use those technicalities to throw out your appeal without really reviewing it. If you're having these conversations over the phone with your insurance company, you want to make sure that you write down the day, the time of your call, ask for the name of the person that you spoke with, and typically they will have a call identification number as well. And then you can take notes on the call, and it will make it very difficult. You know how they always say this call is being recorded? Well, if you go back to them and say, this is what I was told on this date and time, and here's the call identification number, they can't really deny that that's what was said to you, because they have the audio. They're going to pull it up and read it, or listen to it. And those are things like when you get to that, if you need to get to an appeal process, that's where HCC can help. So we can help walk you through that if you have an individual case. I'm going to introduce Lou. Lou serves on the advisory board of the Fair Time for Women Coalition, and she's a woman with multiple bleeding disorders that overcame barriers herself to get diagnosis and care. And she's currently a NICU nurse at her local children's hospital. So Lou, would love to have you come and share a little bit about your story.
I don't know if everybody got the same blurb when they registered that said about that it's, statistically 16 years from symptoms to getting a diagnosis, and the average age of diagnosis is 35. I've been quoted that for over 30 years. Hopefully it's, finally going to change. So I am 65 years old, will be 66 in June. As a child, lots of bruises all the time. What I know now were muscle bleeds and joint bleeds because I did gymnastics and track and field. At 11 years old, I started having GI bleeding, which went on for months and months. Now, if I get GI bleeding, take a dose of Factor and it's gone in a day or two. Started periods, had heavy periods. When I tried to talk to the doctor about it, they would say, well, how was your mother's? How was your grandmother's? Well, they were very heavy too. So then they say, oh, that's normal. But, they had hemophilia too. So then I had first child at 24 and wondered why I didn't have much bleeding because I was used to what my periods were. Now knowing that hormones make your factor levels increase with pregnancy. So I didn't have really, much problems with the first delivery or anything. My son had bleeding with his circumcision, took forever to heal. I kept questioning it, but then finally healed. And at 17 months, he woke up from a nap and wouldn't bear weight on his leg. And so they put him in the hospital. We're working him up for juvenile arthritis and osteomyelitis and giving him aspirin.
Enter your meeting ID.
Giving him aspirin and putting heat on it. And so it was a resident in the middle of the night was listening to my story of bleeding symptoms and said, let me do some, clotting studies on my son, and found out that he indeed had hemophilia A severe. And so then I was just labeled as a carrier. First, and then we went to the HTC to start his care. Back then, there was not genetic testing because they had not discovered the gene yet for hemophilia. So the testing for a woman was to do your PTT, the old barbaric test of, slash your arm and somebody sits there with a stopwatch and see how long it takes you to clot. They usually gave up after a while because it wouldn't clot. And that was it, and got a factor level. But so there wasn't the genetic testing. So forever I was just considered just a carrier. And then years down the road when that was available, then I did get the genetic testing to show that I had the same mutation as all my children. And then I was able, my other children, to look for that particular gene. But with not being diagnosed and still not treated right, I was still having lots of problems. So at 35 years old, I had an inguinal hernia. I went for my, pre-testing for that. When the anesthesiologist talked to me, he looked at my history and saw that I was a carrier for hemophilia. So he said, well, I would like to refer you to a hematologist before I okay you for surgery. So I actually got sent to Dr. Kessler at Georgetown University in Washington, DC, who then did these testing and said, no, you're not having any surgery right now. But I was only put on DDADP IV for the surgery. And that's all I was given at first. So I would still have problems. I moved to Texas, and I'm a nurse. I am not at a local children's hospital. I work at Baylor Scott and White Hospital, just for clarification of that. So I moved to Texas because I actually, now my second husband is, I met, if anybody knows Ray DeToli, is also a hemophiliac, because we met on the HFA board. So as a nurse in there, the HTC is at UT Southwest, which is not network. So I was only seen by what we were talking about before, the hematologist, who's actually an oncologist. So my care has always been as good as whatever my knowledge is, because I write my orders, he signs them. So was still struggling, and I did not get access to Factor until about 10 years ago, that I can treat more regularly, and also found out from talking to other women's at women's retreats and stuff about Lystata, or tranexamic acid, which has helped a lot with bleeding. Because even since a kid, I would bleed from just dental cleaning and just be yelled at that I mustn't be flossing right. So now at 65, I have joints that are bone on bone from joint bleeds that weren't treated when I was younger. A lot of arthritis, damage to my large intestine from the bleeding I had when I was a kid. So I want to see it that other, that it becomes that women get diagnosed earlier and get access to proper treatment. So thanks.
Thanks so much, Lou, for sharing your story. I want to turn it over to Ashley to share a little bit about the FAIR Coalition.
Yeah, thank you, Lou, for that compelling story of barriers to care. And thank you, Lynn and the Hemophilia Council, for hosting this important topic. Unfortunately, as many already know, Lou's is not a unique story. Women, girls, and those assigned female at birth with bleeding disorders are facing barriers to care. We have one goal, and that's to increase access to diagnosis, care, and treatment for women, girls, and those assigned female at birth with a bleeding disorder. It's important to recognize that hormone levels can make factor levels fluctuate, and this can cause treaters to be hesitant to use clotting factors in an effort to avoid thrombotic events. We have partnered with treaters that have created an algorithm to address the many questions that arise when treating persons with two X's, and this will be revealed soon. Next slide, please. You are welcome as a community member and stakeholder to join our coalition as we move toward these objectives, enhancing awareness and increasing the collective storytelling of women, girls, and those assigned female at birth with a bleeding disorder. Next slide. Our projects are well underway, and we welcome you to be a part of it, and it's not too late. Please ask, we welcome everyone. Let's get your local HTC clinicians to sign on to MASAC number 264, which is the recommendations regarding diagnosis and management of inherited bleeding disorders in girls and women with a personal family history of bleeding disorders. Let's also get them to sign on to HFA's Bleeders Bill of Rights, which was created to empower partnership with treaters and patients with bleeding disorders. Look for our toolkit designed by our advisory medical team to enable reporting and conversation between patients and their treaters. Fair Time for Women website is launching soon and will be the one place for all things related to this topic. We will refer to all the national, regional, and local programs, organizations, and resources available. Watch for our updates and meetings, and I'll put the socials in the chat. And I just want to thank you again, Lynn, and the council for having us.
Thanks, Ashley, and thanks for adjusting and I appreciate, I know you had a little bit more in there, and you skipped through it quickly. So I'm going to go through a couple of wrap-up slides. So I want to mention, in addition to the FAIR Coalition, there really are a lot of great resources out there. I wanted to give credit to Dr. Jen Johnson, who, like I mentioned, her presentation, Better You Know, is a campaign by the National Hemophilia Foundation that has some amazing tools on it for men and women who are looking to think, I might have a bleeding disorder, what do I do? They have some questions that you can take yourself through, and then they have some great resources you can download, a healthcare diary, information about testing, a lab test log, and then some questions you can ask and write down the answers to in preparation for a doctor's visit. Those are great tools. Related to sort of the insurance appeals side, NHS has the health insurance toolkit, and My Patient's Right is another great website with some really wonderful tools. Quick overview, this fall we are going to be doing a series on insurance and how to navigate your health insurance pathway for the best results for you. And so keep eyes open for that. Wanted to thank our sponsors again. We thank you for joining us and open it up for questions for those that have more questions or comments that they would like to ask. I tried to answer quite a few questions in the chat, but happy to entertain questions if someone wants to unmute or has something that they want to throw in the chat before you go.
So I've had genetic testing done, I've had chromogenic testing done, and all of my testing shows 2 bleeding disorders, but the HCC still only wants to treat one of them.
You said the testing shows 2 bleeding disorders,
Yeah.
but so far you're only getting treatment for one of the bleeding disorders. Yeah, so that's interesting. I mean, part of the trick for that is that you know, like I'm going to use myself as an example, right? So like I absolutely have a bleeding disorder. You know,
Yeah.
my family history confirms it. How genetics works confirms it. I have a genetic test that confirms it. And I have factor levels that confirm it. Thankfully, in my personal experience, I'm not particularly symptomatic, right? I do have some symptoms, right? Like I definitely bruise more easily. And there's been a couple of times in my life where I have been able to access treatment in a like prophylactic kind of way.
Yeah.
And I don't know if I would have had a more severe situation. The reason I say that is because you could have a bleeding disorder and that you could have 2 bleeding disorders and they may just not know which of the 2 are causing your symptoms, right?
Yeah.
So you're gonna just document as much as you can,
Yeah.
and do your best to work collaboratively with those physicians. And I mean, ultimately, if you're still struggling and you think, gosh, I'm still experiencing too many symptoms, you know, you may have to look at, I mean, we're lucky in California, we have many excellent treatment centers here. You know, it may be at some point a time to say like, hey, I'd like to get a second opinion on this.
Yeah.
And,
Like
and seek that second opinion.
I've pretty much been directed to the conclusion that I'm probably going to have to go down south and seek out treatment centers down there, which I have DHCP, so it's pretty much taken anywhere as an HCP.
And I will also say this. I will also say, you know, sometimes you want to do it in a respectful way, right? You want to be able to work collaboratively with those physicians. And I also know people who have stories where they got another set of eyes on it. They got a good treatment protocol in place, and then they were able to go back to the original treatment center that is closer to their home. And because they had like an addition, you know, they were able to then consult with a different center. And that brought a better conclusion to the situation. So just because you go and get a second opinion from somewhere else doesn't mean that you won't ultimately be able to get care at the location that's closest to your home too. So, I mean, yeah, happy to, if you have further follow-up that you want to do offline without that, my email address and phone number are like up there on the slide. Feel free to take that down and reach out to me individually if we can, you know, explore the specific options, you know, further. There was also
I'm like, you said it's on the slide. I'm blind.
Oh, it's on the very bottom of the slide, but I'll put it in the chat too, just in case that's easier to cut and paste. Maybe it's not showing up very well on there. I also saw a question in terms of the recording. It does take us a little time to, you know, edit and post the recordings sometimes. But if you go to our website, that takes you to where our YouTube page is, and you can get to all of the webinar recordings. Oh, Andrea beat me to it and put my information in the chat. So thanks, Andrea, if anyone wants to grab it. So anybody else want to raise their hand, ask a quick question before we log off? We've probably got some Sacramento and Bay Area.
Sí, yo.
Yeah. So, okay, go ahead. We have a couple questions.
Mi nombre es Talia.
Hi, my name is Talia, and look, my daughter, well, I have 4 children, 3 boys and 1 girl. All 3 were diagnosed with severe hemophilia B, the 3 boys, and my daughter was diagnosed as a carrier. However, she has had multiple nosebleeds. In fact, I get called by the school almost every day to tell me that my girl is bleeding from her nose. She has low iron count.
Okay, hold on. Carlos, I did not hear the translation of that. Are you able to switch over and?
Can you hear me now?
Oh, shoot. Okay.
Del estudio.
Yeah.
Okay, can you hear me now?
Just a second, I'm sorry. I
Can you
had
hear me now?
technical difficulties. I thought I had English translation turned on, but I don't think I did because I didn't hear Carlos's translation.
Can you hear me now? Can you hear me now?
Disculpa, ¿vuelvo a repetir?
I'm sorry, should I do it again?
Ashley, did you hear the question?
Ashley, did you hear the question?
Yes, I think the question was that her daughter is having excessive symptoms, especially nosebleeds every day at school. And she's wondering how to get the treaters to maybe believe her so that she could move on to testing and some appropriate treatment. Did that sound right, Carlos?
Así es. Quiero saber qué nombre de qué estudio.
Yes, what I'd like to know is what kind of tests I should request for my daughter.
So
What's
she'd
the
like
name
to
of
know-
it?
She'd like to know what the name of the tests are. Oh, you heard that, Lynn?
Está bueno,
No,
no,
no.
Oh, okay.
más o
It
menos.
sounds like this person may
No muy
need
bueno.
specific attention from the council.
Oh,
Yeah, so let's do this. Andrea, why don't you go ahead and put your contact information in the chat. So Andrea works on our team at the Hemophilia Council, and she is bilingual. So she can get on the phone with you and get a little bit more specific information about your situation, and we can see how we can help you get to someone who will be able to hopefully assist you better. Because I in terms of what
Perfecto, muchas
specific-
gracias.
That would be perfect, thank you. And if you can send me all that information all to my email, this is all very important to me. Thank you.
You're welcome. And so I think there was a second question also. I don't know if we got to that one. Was there another question that someone wanted to ask?
Yes, I have a question really quickly. So I have 2 boys with hemophilia A severe, and I've been bleeding as I age. I had my kids when I was 19. I'm 42 now. As I'm aging, I've noticed that I'm bleeding more. When I had my first child, I'm sorry, my last child at 27, I was bleeding a lot. anytime I get dental work or anything like that, OBGYN procedures, it's just excessive bleeding. I decided to go get checked out. They did factor levels, they did all that, and everything came back normal. But I mean, even my own dentist was concerned because he thought he hit a nerve or something, because I wasn't healing. It took about 8 weeks or so for me to heal. So this is becoming a concern to me. And I went to go see 2 different hematologists, and they said my factor levels are normal. I'm getting ready to go and get a second opinion. I decided to put that aside and decided to just go and get a second opinion. I mean, my life matters, so I need to go see what's going on. Has anybody else experienced anything like that?
I think that is not an uncommon story. Unfortunately, I mean, I've heard variations on it. I think that one of the things, and I mean, Ashley had noted that they think that perhaps people with normal factor levels can also bleed. I don't know that exactly is the way that I would phrase it, but there is definitely evidence that suggests that the genotype of that you carry, so like what your mutation is that's causing, whether it's hemophilia A, B, VWD, etc., is more tied to the amount, like how a person bleeds, than potentially what the factor level is. And so that's very preliminary information. It's something that they haven't been able to study nearly as extensively as they need to. But I think that, I think one of the ways that I've heard it phrased in the past is it's like we should treat the bleeding, not so much the level, right? So the treatment should be based on how much is the person bleeding, how much is it impacting their life, and what can we do to deal with the root causes of these symptoms, as opposed to being so caught up in, oh, well, it's all based upon what the person's level is. So again, feel free. There's been a couple of them great points. The lab that is doing the testing needs to have expertise. Sometimes mishandling of the lab work can impact the levels. As been mentioned before, our hormones can affect the levels. So like if you were anxious when you were getting the blood work done, that can raise your level. Depending on where you were in your cycle, that could affect the level. So it's certainly something that, as much as we don't like to get poked, sometimes you need to have the test a few times to really sort of see where you land. And I think some folks have made some similar points about that. So you want to, and hormone replacement therapy could also affect levels. So I think that those are options to, talk to your doctor about. And again, I'll copy and paste my information in the chat. If you want to email me, feel free to email me a little bit more specifics as far as like where you've been seen and that type of thing. And maybe I might be able to make some recommendations of a good place to try to go for a second opinion.
Thank you so much. Thank you. This is really good information. So I'm really gonna get this started again. So yes, thank you. I just recently went to my doctor's hematologist, and I brought it up to their attention, and they're like, definitely go get checked out. You just need to go get checked out. So, but thank you.
Yeah.
So I'm gonna start this journey again, and I hope I get some answers. Thank you.
Absolutely. Let us know how we can help.
Thank you so much.
All right. Well, thank you everyone for joining us tonight. Please feel free again to use the email or the phone number to reach out to us if we can assist you. And really appreciate those of you that shared their stories. I guess there was another question that had come into chat, like as far as when the best time is to check your level, I think is what they're maybe asking. And to be honest, I can't speak to that I'm not a physician, so I'm not exactly sure about what that is. So that's where I would encourage you to make sure that you're working with a hematologist that has expertise in this. And I think that question was originally asked in Spanish. So feel free to reach out to Andrea with any more follow-up questions so that we can help you get connected to the right folks. So that can assist you. So thank you again, everyone, for joining us. Hope you have a great evening. And as others have said, we really wish you all the best to those that are still on their diagnosis journey. And we will do our best to help you along that pathway. So thank you for coming tonight. Good night, everyone.